Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, June 24th, 2022, our topic is the Supreme Court decision to overturn Roe v. Wade. I speak to Dr. Reagan McDonald Mosley, an obstetrician-gynecologist and the CEO of Power to Decide, a private, nonpartisan, nonprofit organization that, and I'm quoting here, works to ensure all people have the power to decide if, when, and under what circumstances to get pregnant and have a child. Let's listen. Dr. Reagan McDonald Mosley, thanks so much for joining me so quickly after the Supreme Court's decision in the Dobbs case.
Thank you so much for having me.
I really can't think of anyone I'd rather talk to about this decision, given your work in this area. Could you give our audience a little bit of a background to your career?
Sure. I'm an obstetrician-gynecologist with a background in complex family planning training. But I think the interesting thing to note is that I actually became a doctor in part to provide abortion care. As a young college student, I had the opportunity to do research in sub-Saharan Africa and Moshi, Tanzania, and found that unsafe abortion was the leading cause of death for the Moshi region of women in Tanzania. And not only did I see that in the medical records, but I actually witnessed, people coming into the hospital with severe morbidity. And sometimes I saw women die in just the short 3 months that I was living and working in Tanzania. So as a young college student, I was sort of on this path to address this issue. And I never could have imagined that the moment would come where in the United States, abortion care would be restricted over half of the nation. So you come to abortion not as a legal theory or a legal case, but as a matter of life and death. Absolutely. And that's my personal experience of having seen women die from lack of access to safe legal abortion in sub-Saharan Africa. And that also has been borne out in the literature, right? We know that in places where abortion is highly restricted, general pregnancy outcomes are worse. And that is one of the things that keeps me up at night, knowing that that's to come in this nation. We already know that we have a maternal health crisis in this country. And we know that Black women specifically are 3 to 4 times more likely to die of pregnancy complications compared to their peers, even when considering other factors. And we know that this is going to get worse as people have less and less access to abortion, because that means that they will also have less access to care for complicated pregnancies, miscarriage management, early pregnancy failures, ectopic pregnancy, and more. Tell us a little bit about your career as a OBGYN after you went to medical school. Yeah. So as I said, I went to medical school in part to do this work and enjoyed the journey and every single rotation that I had while at the University of Pennsylvania, but always kept being drawn back to the work of women's healthcare, reproductive healthcare, and abortion access specifically. I then had the opportunity to do my OBGYN training at NYU Medical Center, which was an amazing place to train, a diverse place to train. And I had the opportunity to take care of people from all over the world. And then I moved to Baltimore to do a 2-year fellowship in complex family planning, where I had the opportunity to, again, return to sub-Saharan Africa and do work and research and training in complex contraceptive management. And during my fellowship, I had the opportunity to work once a week at the local Planned Parenthood, where I loved the model of providing care to people no matter what, no matter their income status or insurance status. And then ultimately ended up becoming the medical director of the local Planned Parenthood, and ultimately also serving as the chief medical officer of the National Office of Planned Parenthood. And then a year and a half ago, I had the opportunity to become the CEO at Power to Decide, which is a nonprofit organization that does not deliver healthcare directly, but operates in the digital space where people are more and more looking to information about sexual and reproductive health and health overall. And we work diligently to make sure that people have access to reliable evidence-based information in the digital space and can connect to care more easily. So your career has been really defined by helping people get access to abortion when they need it, as well as other kinds of family planning. This is an enormous day for you. What's your day been like? I'm really lucky in that today is a rare patient care day for me. So I get to just focus on the individuals in front of me and taking care of them and supporting my staff who are all very upset and concerned about this decision. I think later today, I'll pivot again to thinking about the broader public health implications and what this means for communities, particularly for the communities that are going to be most impacted, right? And we know who those folks are. We know that this is going to impact people of color specifically. We know that this is going to impact people who navigate the world with lower incomes disproportionately, as well as people who live in rural areas and young people.
You mentioned a shocking statistic before, which is that there are gaps of 3 to 4 times in the rate of death for Black women, elevated 3 to 4 times. And you said you thought it would get worse. Could you talk about that?
Yeah, there's been a few demographers who've done some modeling studies already that have indicated that there'll be a significant increase in maternal mortality after, Roe v. Wade is overturned, which, that day has finally come. And those projections are without an increased incidence of unsafe abortion, right? Just because of the lack of access to abortion care itself, lack of access to miscarriage management of early pregnancy failures, et cetera. All of those things are linked.
So could you help me understand that a little bit better from your clinical background? Like, what is the patient that you're worried about in that setting?
Yeah. So unfortunately, we're already seeing this happen in Texas, right? Where in September of last year, abortion has been highly restricted and pretty much unable to be accessed after 6 weeks. And we've already seen cases in Texas where people had early pregnancy complications, such as a woman who reported having early rupture of membranes pre-viable at 19 weeks, in which case her doctor would normally say, these are your options. One is we could wait and see what happens. The other is we could intervene and remove the pregnancy, decreasing your risk of having developing sepsis or an infection. And the doctor said, but in this case, I don't feel like I can, based on this law, provide you with what is best evidence-based care. And so the doctor and the woman, had this long conversation about what to do and what her options were. She could drive across very desolate, isolated areas, but risk going into labor and having complications without any access to medical services. And what in the end she ended up doing was getting on a plane and flying with ruptured membranes at 19 weeks to New Mexico in order to get the care that she, should have been able to get it right there in Texas. And so, this was one of the cases where this woman was able to navigate all of this and had the financial resources to travel to New Mexico. But we know that many more people are going to have barriers and not be able to connect to the care that they need and may end up having severe complications and morbidity.
I don't think I fully appreciated this before, but what you're saying is that there are clinical situations where abortion has been and should be an option to protect the health of a pregnant patient. Now, where that option is no longer available, the consequences could be lethal.
Yep. In other severely restricted environments, including in other countries, this is also extended to the treatment of ectopic pregnancies, where if there's a heartbeat in a fetus, they wouldn't intervene for an ectopic pregnancy, which can be life-threatening, right? And just overall, we also know broadly, right, that when we decrease access to care in places that provide abortions, those are places that also provide other care, miscarriage management, STI testing and treatment, cervical cancer screening and breast cancer screening, contraception. All of those things are also going to be impacted, right? Because as clinics close, as staff move on to other things, there's going to be less capacity to provide these broader range of sexual and reproductive health services to the communities that already have significant barriers to accessing this care.
So we've been talking about the direct health impacts, which are going to be considerable. You have obviously cared for many people who are making the decisions that they need to make for their lives, and you're, counseling them. The implications for health go beyond the direct medical impacts, though. And I wonder if you could speak to that a little bit.
Yeah. And this is also well documented due to a groundbreaking study called the Turnaway Study that was conducted by Dr. Diana Green Foster and researchers at UCSF. It was a longitudinal study where they followed people over the course of 10 years and documented outcomes based on whether or not people were able to obtain abortions and whether or not they weren't. And again, what this groundbreaking study found was that for people who were not able to get an abortion that they needed or wanted, that they were much more likely to be living in poverty over time, that they were far less likely to have long-term employment, that they were more likely to be staying in abusive or unsafe relationships, and had also health implications based on the pregnancy that they had to carry and broader health implications. And that lastly, that their children that were already existing, again, recognizing that most people that have abortions already have children, those children were less likely to meet their developmental milestones. And so this will have broader socioeconomic implications for people in communities, particularly in states where abortion is going to be highly restricted.
Given how much is at stake and how much of your career has been put to this, I'm impressed that you're able to see this analytically at this difficult moment.
I mean, I've literally spent the last 20 years thinking about optimizing people's reproductive well-being, and I'd love to be working on innovative digital tools and fun ways to reform their healthcare system to optimize outcomes. But the reality is that right now, what we're working to do is mitigate the significant harm that's going to come from these laws. And I think it's important for people to recognize that this is not normal. This is not what's happening in the rest of the world. There's actually a global tide to increase access to abortion, including in Central and South America and other parts of the world. And so we cannot sort of accept this and sit in this space as just the new normal. We have to do everything within our power to change this, both in the medical space, in the legal space, and everywhere where we can have influence to not only mitigate and connect people to care in the moment, but change this reality in the future to optimize people's well-being in the long run.
I guess what I was thinking is that I don't think anybody would blame you, and I certainly wouldn't if today was a day just to kind of put your hands on your head and go like, I can't believe what's going on, But it sounds like you have been thinking about this and you're in the, okay, roll up our sleeves, there are people depending on us kind of frame of mind.
That's right. I mean, and sadly, I've had a month to adjust to this sort of after the leaked draft opinion came out and to know that this was going to be the new reality. And of course, I was holding out hope that this wouldn't happen, but also preparing for the worst.
For those people in public health who are holding their head in their hands right now, who are wondering what the future holds, what would you say to them?
I would say that now more than ever, we need to be prioritizing people's sexual and reproductive well-being in any way that we can. And that means breaking down barriers at the state level to optimize access to contraception. That means ensuring that people who need or want abortion care can connect safely to that care, ideally in their own communities. And that's going to take a network of support, of finances. That's going to mean more and more healthcare providers are acting as social workers and travel agents. But whatever it takes to connect people to this essential care is what we should be focusing on, while we're also working to change the tides, address the laws, and ensure that the next generation is not still dealing with this situation.
Dr. McDonald-Mosley, thank you very much for taking a few minutes today to talk to me.
Josh, it's my pleasure, and thank you for highlighting this important issue.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.